Going to the dentist is to some just a routine necessity that we subject ourselves to once or twice a year. But for the millions of people who suffer from uncontrollable dental anxiety and phobia, visiting the dentist can be one of the most stressful events that is often avoided at all costs. It is suggested that up to 80% of people in the United States alone suffer from some form of dental anxiety. When we look at dental phobia as not just something unfortunate that happens to others, but in terms of cost as to the patient, to the dental team, the healthcare system, we see how detrimental it is. For instance, consider the cost of postponed dental care, the cost to the dental team, days lost from work, the cost to the patient, the cost to the corporations, the cost of untreated problems, the cost of loss of self-esteem, depression, isolation, mental illness. The list goes on and on. These are quite significant statistics when we look at them, and yet dental phobia is not taught in undergraduate dental school. Moreover, it is sometimes trivialized in some dental circles. And yet studies indicate that dentists perceive that treating dental phobia is stressful. Dentistry has been identified as having been perceived as one of the most stressful health professions. Interestingly, not because of the stressfulness of the practice of dentistry itself, but because of the personality traits of the people selected by a rigorous elimination process to be dentists. The historical selection process ensures that certain personalities with specific traits are targeted and attracted into the profession. Historically, these personalities are then nurtured by the institution into a sort of culture of dentistry. Some of these traits include perfectionism, competitiveness, compete control, hierarchical control, autonomy, and in many, but not all cases, a subscription to a severe type A personality. A phobic patient has symptoms that violate every one of these highly targeted and nurtured type A personality traits. So it is pretty easy to see how an average type A personality dentist would have a pretty hard time dealing with such a patient if not specifically trained to do so. For example, the energy of fear in phobic patients creates chaos, and it sort of violates a type A's perfectionism. The art of eradication of fear in a phobic patient requires negotiation and a non-hierarchical team effort because of this fear's multifaceted disciplinary health nature. It does not require autonomy. Another example is a team effort in treating patients with dental phobia have to work in a complementary fashion and not a competitive fashion, and never in a hierarchical fashion, because different people might be needed to switch into different positions at different times. Irrational fear, which the phobic patient exhibits, cannot be controlled. A type A personality and an irrational phobic patient do not mix naturally, surprise, surprise. And yet, ironically, what they have in common as their root cause is the same underlying fear. In one, the type A, it's a fear of not being good enough. In the phobic patient, it's the fear of total loss of control, which is what happened to them. So is it any wonder, therefore, that most phobic patients are managed rather with sedation and general anesthetic, both of which, though sometimes absolutely necessary, ignore the root cause of the phobia, which normally stems from dentally induced trauma in childhood. So let me introduce myself. My name is Dr. C.A. Beautray, Jr. I come from a long line of pioneer educators and even dentists. My father, Dr. C.A. Botre Sr., founded the first dental school in Ghana, West Africa. He was trained at King's College University, same as me. I have been a dentist for 27 years. I have a master's and a diploma in dental public health from King's College School of Medicine, the University of London, the Royal College of Surgeons, and the Royal College of Surgeons London. I have a licentiate in dental surgery from the Royal College of Surgeons London, and I've written articles on stress and dentistry, one in the CDA journal, Canadian Dental Journal, and have produced strategies for my patients over the years for them to unlearn the unnatural fear of the. So my interest in this subject began organically. The story of this journey is quite vital in understanding why I so passionately believe that this subject must be taught in undergraduate dental school, and this teaching must definitely be part of and available to every dental office as a resource. In 1993, I graduated from dental school and went immediately to work as a very green associate at a private practice where the focus did not appear to be on the patient per se, but rather on the bottom line, as many associates found out to their shock. And in line with this philosophy, I was called into the boss's office one day and I was instructed that it was my duty as a dentist in that clinic to persuade the very next patient who walked in to have a crown, whether they needed it or not. Fortunately, I had been taught by my mentor, my father, who built Ghana's first dental school, as I already mentioned, what my duty as a dentist actually was. So I instructed the patient he did not need a crown, but rather he needed to improve his oral health, hygiene, change his diet, reduce sugar, and keep his 6-monthly appointment. And then I dismissed him. The boss was furious and insisted that we try again the next day. This is not typical of normal dental clinics, I assure you that. So I resigned. And when a salaried community position arose where I could actually look after my patients without having to cater to such unsavory internal demands and policies, I took it. And my journey began, my adventure began. And that took me to a quaint, beautiful, quiet English hamlet in Oxfordshire, where the National Health Service needed a dentist. And there were a couple of us, I guess, to take care of the overflow of patients who were not able to be seen by the private practitioners. And these patients just happened to be high risk, sort of lower socioeconomic patients, and it just so happened that over 80% of them had some kind of anxiety. And now, whilst I had been to one of the best dental schools in the world, King's College London, School of Dentistry and Medicine, and I knew how to do pretty much everything to do with dentistry, I had actually never been taught how to treat an adult phobic patient. But without knowing what to do about their anxiety, I couldn't effectively do the stuff I had actually been trained to do. And as I was the only dentist that they could see, I was actually it. And so I had to learn really quickly. I began to research and learn from practical clinical experience. It was very hard and very stressful. I had to learn what was behind all of the hostile greetings of, I hate the dentist, I don't want to be here. Sometimes I would be greeted with, I hate you, I don't want to be here, that kind of stuff. It was very difficult, and I soon realized that the problem, or their problem, was a belief system that had been created in childhood from a trauma, mainly in a dental office. Well, this was shocking to me to realize that the phobia that was creating the barrier to dental care had been caused by us, by the dentists. I had never learned in dental school, as I said, other than in casual mention, anything substantial about dental trauma, its genesis of dental phobia, how to address it, how to liaise. The only division of dentistry that vaguely appeared to address dental phobia were the divisions of community dentistry and dental public health. So To further my understanding of the minimal progress I had made through trial and error strategies, I enrolled in 1994 into a master's program at the University of London, King's College, in which I learned about belief, traumas, thoughts, perceptions, and their roles in creating negative behaviors in healthcare. As part of my program, I worked briefly at a hospital for patients who, some of them could not communicate through normal means due to brain injuries. And it was there that I learned something that would help me to no end with my phobic patients. I learned non-verbal communication. And though many could not speak, with the help of the occupational therapists who I ran to for help and said, "You have to help me, I can't understand what Mr. Smith wants," they taught me, and I learned how to communicate with them non-verbally regarding dental care. And it was very surprising to me because I knew nothing about this. So I had to liaise with other members of the team and have them teach me and show me, and that really helped me in nonverbal communication. What an adventure! I also worked in this time period in a pretty rough West End neighborhood of a place called Hackney in London, and here many of the patients again were high risk, socially compromised, and very phobic. And it was here that I learned many lessons in the art of departing from the autocratic old medical model that I subscribe to. So I subscribe to that. And with that model, I could not treat phobic patients. It was such a barrier. When I let go of it, it was like a whole new world. And instead, listening and negotiating with the phobic patient on their strategy plan, which began to build trust, which is the cornerstone of ever treating a phobic patient. So all of these things were wonderful. I got my master's degree, I got my diploma in public health from the Royal College of Surgeons and all of that good stuff and all the adventures that I had. But it was my unexpected and extremely reluctant trip I turned this job down about 3 times to the isolated town of Churchill Falls, Labrador, in 1996 that really showcased and put to test the fruit of experience and understanding that had been attained by my training and my education. I was able to treat the entire town, most of whom were nervous and untrusting of the role that I was in, the emergency dentist who would fly in. I was in there. I was actually living in there for a few months. In addition, the town asked me to stay, and a permanent position was created. My subsequent ability to deal well clinically with difficult patients was rooted in the fact that most difficult patients are phobic patients with dental trauma as their underlying case. So once in private practice in Alberta, I set about creating a private teaching program that I presented to most of my phobic patients free of charge, and these practices were easy peasy. They were low cost, and if practiced, they actually worked. Working as a clinical assistant professor at the University of Alberta in 1996 to 2001, I was extremely privileged to be involved in a new course for the first and second year medical and dental students called POM-D, for the practice of medicine and dentistry. And it involved mainly overcoming tangible and non-tangible barriers to healthcare by employing the entire medical team in a patient-centered care model and leaving behind the old autocratic medical model where the dentist or the doctor was the king and everyone else was, sort of in that hierarchical under progression, leaving that old model that I had subscribed to, I had been trained to, leaving that in the dust. In 2001, I designed a dental-specific curriculum which cited phobic issues as part of its specific dental-specific scenario. The program I offer to my patients has been updated, revised, and tweaked through the years. It's based on current research borrowed from various divisions of medical teams and is offered free of charge to my personal patients. Now, this program vastly differs from lots of the free dental anxiety information offered on many websites. Firstly, because I do not advocate sedation or GA in my program. I base all of my program on what works, on research-backed clinical experience and implementation of what works. So let's look at some of these websites. Some websites advice focuses on sedation, like we said, which we don't include in the program, GA, or factors that are outside of the patient, like, for instance, improving scenery of the dental practice, aromatherapy, kindness, music, providing music, gentleness, providing knowledge, explaining procedures thoroughly is advocated. And whereas all of these things definitely enhance the procedure, none of them will in of itself heal the patient, because the root cause of the patient's phobia is not outside somewhere there. It is within their belief system, and that is why we cannot control it. The ability to empower the phobic patient towards that path of healing is totally inaccessible to a dentist who operates in a specific type A mindset. Now, whilst that mode of operation might have qualified me and deemed me to be worthy to enter the profession of dentistry, it completely disqualifies me from truly finding common ground in which I can empower the patient onto that path of healing. In the state of severe type A mode, the only common ground I can find with the phobic patient is we can only overlap or find common ground in fear. That could be the only thing that we could find common ground in, and that is obviously unacceptable to both. So we realize that it is the patient who has the power to unlearn the learned trauma, and it is the dentist who, in order to assist the patient on this path, must step outside of that type A self-imposed boundaries and become the guide, the scribe, whose expertise, training, discipline, compassion, and authority and ability to work with other health disciplines can greatly empower and accompany the patient to that patient-centered path to recovery. It was never easy to acquire this knowledge, but without the noble profession of dentistry, I would not even have had the opportunity. Many times I didn't know what to do, and sometimes I even wanted to give up. Few people thought this work was important and showed little interest. The patients didn't seek this, as they wanted to avoid dentistry at all costs, remember. I almost gave up. But my mentor once told me that when your work becomes joy, know that you're on the right path. And the day I helped my first patient, Judy, overcome her fear, I felt that joy and I knew I was on the right path. I have been honored for the past 27 years to be a dental scribe and a dental guide along the path that leads phobic, anxious, and fearful patients to choose and to embark upon a transformational journey from terror to the promised land of empowerment, where the sky for them is the limit. My name is Dr. C.A. Beautray Jr., and I want to thank you for listening.